Thanks for inviting me to speak today, and this is really a terrific new conference. I'm going to be speaking on who should undergo CTO PCI, and I'm going to come at this with maybe a little bit of a harder edge than maybe you're accustomed to, because I think that there are risks and benefits of CTO PCI that we need to consider when we think about who should undergo PCI for our patients. These are some of my relevant disclosures. So deciding who should go undergo CTO PCI is really an exercise in weighting of risk and benefit. And possible good reasons to offer CTO PCI to a patient include improving symptoms and improving prognosis potentially, and maybe in some patients both. And so I'll dive a little bit deeper into what are the evidence behind either of those two claims. And then there are possible good reasons not to offer CTO PCI, and that is for some patients you just might not help them, right? So you can fail with your procedure. There can be, even with a successful technical procedure, there may be a lack of clinical benefit. There is a higher than average target vessel failure rate. And so these may be legitimate reasons for one to say, well, even though I can do CTO PCI, maybe I don't want to offer it. So how do you think about these? And then most importantly probably is that you may harm the patient. So you can have complications, and the complication risk is not trivial. And so part of what learning and coming to a course like this is learning how to minimize those complications and identify patients who benefit the most. So first question to help us answer this is do CTO patients have symptoms, and do they get better with treatment? So in the first case scenario, we know that many patients do have CTOs. Upwards of nearly maybe 20% of patients who undergo coronary angiograms have a chronic total occlusion. The evidence that we have showing that the CTO PCI benefits patients up until very recently was really limited to observational data, taking symptoms before a procedure, measuring them after a successful procedure. And in this study by Aaron Grantham et al. On the right-hand panel, you see that patients did have improvements in all the measures of Seattle Angina Questionnaire, which is really our best measure of angina for patients after successful CTO PCI. There are also improvements in dyspnea, which is a common symptom associated with CTO PCI, even in the absence of angina, and actually improvements also in depression scores. And Farouk and I have had a paper looking at that as well. So what about decision CTO PCI? And so you remember, or we'd like to forget, that in decision CTO, this decision CTO trial, there was actually no symptomatic benefit associated with difference between the two randomized treatment arms. And what's most important, I think, to remember about this trial, and why it would diverge from what I think most of us think or observe clinically to be true, is that this was really not a comparison of CTO PCI versus optical medical therapy as it was originally framed. And I suspect that this is part of the reason we haven't seen it in print yet. 75% of patients had multivessel disease, and so non-CTO lesions were stented after randomization, actually, in both arms. And as a result, it's actually ended up being a trial comparing PCI versus PCI, and in that situation, it's usually a tie. As opposed to the decision CTO trial, the Euro CTO trial took care of the non-CTO lesions prior to randomization, which you need to do in order to really isolate the clinical benefits of CTO PCI. And here, I think, as we would expect, we did see a clinical improvement in all the measures of Seattle Angina Questionnaire, again, with physical limitation, angina frequency, quality of life, significantly more patients who are angina-free after this. This paper hasn't been published yet either. These are the results that were presented at Euro PCR. Okay, so we know that CTO PCI improves symptoms, but do all CTO patients have symptoms? And I think some of the evidence for this is that maybe we seem patients sort of minimize their symptoms and they're present when you look for them. We do have FFR data, this sort of seminal paper by Gerald Werner's group, showing that if you FFR a CTO, you cross it and you put an FFR wire before you do it, nearly all, in this case, all patients had significant FFRs that would have met criteria for ischemia. Look at some of these FFR values are tremendously low. And I think if you think about how slow the flow is across collaterals, we're not really surprised that this is sort of equivalent to a significant lesion. But then when you look at other trials, like this is data from the Open CTO registry, the distribution of Seattle angina frequency, there are actually a fair number of patients who undergo CTO PCI who didn't have symptoms, although that's the biggest column, actually. So that was the group of patients who had Seattle angina frequency scores of 90 to 100. So although I think that in most of our CTO PCI studies, most patients are symptomatic and we show benefit, it's important to realize that those are a selected group of patients who are selected for CTO PCI. I think it's not fair for us to say, I think we need to be realistic, there are, in fact, many CTO patients who don't have significant symptoms, certainly not life-limiting symptoms, that can be adequately medically managed, and that's part of the reason why I think the decision CTO study was negative. So my takeaways from this data is that some, but not all patients who have CTOs have angina. Many get better with non-CTO PCI alone, and many can be controlled with medications. But the remaining few, or remaining many, depending, I don't think we know the answer to how many of those are, those patients who have angina plus a CTO will improve with successful CTO PCI. And so the population really with the most to gain, if you sort of apply this, is those patients with severe symptoms on maximal medications. That's, to me, the no-brainer of the indication for this procedure. It's where we have the least to worry about that we're offering good for our patients. Now, what about this argument that CTO PCI improves prognosis? I think that you're going to attend more and more conferences where people try to make this argument that look at the data behind it. And the data that they will show you will be something like this. Right, that successful CTO PCI seems to be associated with improvement in survival compared to unsuccessful CTO PCI. They'll show you another trial that shows basically the same thing. Those with complete revascularization have less mortality on the bottom line compared with those with either incomplete or failed partial revascularization. Here's data from the syntax score. I myself will use this and say that a residual syntax score is associated with higher mortality. The problem with all of this data is it's observational. And so at best, I would say that this is hypothesis generating. At worst, it may be impossibly confounded. I don't think we should rest our laurels on this data to offer high-risk procedure to a patient who does not otherwise have an otherwise strong indication for PCI personally. That is my personal opinion, and there may be disagreement in the room. And the reason we can't do that, I think, is because CTO is not benign. Were CTO PCI a benign procedure, I think we could rest on that and say, okay, I may be offering you prognostic benefit with CTO PCI in certain circumstances, but it's not benign. Right? This is Manos' paper from JACC Interventions showing that CTO PCI in this country is performed at a significantly lower success rate, 61.9% despite improvements, and a much higher rate of MACE compared to non-CTO PCI. You say, well, this is inexperienced hands. But even in experienced hands, CTO PCI is associated with a high rate of complications. So this is an open CTO registry. The operators that you see present at live conferences, a 0.9% procedural death rate, 7% MACE rate, 2.6% MI rate. Look at the perforation rate, 8.8%. Not a benign procedure. Don't try to convince yourselves or other people that it is. And it's one of the reasons why you're here and learning to make this a safer procedure. And in particular, it's those retrograde procedures we know that may present unique risks. Here, retrograde in those first bar associated with nearly twofold an increase in MACE compared to antegrade alone or even overall other PCI. Manos and others have created factors that maybe help us ascertain the risk and quantify the risks of PCI. And so there's the Progress CTO scoring system, which basically looks at three factors: how long is the lesion, how old is the patient, and do you use a retrograde approach? And those three factors determine much of the risk associated, the MACE risk associated with CTO PCI. Obviously, there are other factors: renal failure, calcium we know is a big barrier to success and an increase in complication rate, bleeding risk factors, vascular disease, and frailty. So taking that into account, who should undergo CTO PCI? Well, I already said symptomatic patients, but really specifically, it's those patients for whom the risks of the procedure are outweighed by the expected benefit. You can use some of those tools to help individualize what the risks and the benefits are. It has to take into account your personal complication rate, your personal success rate, because it's different among all of you, the specific risks of the approach, and how badly impaired the patient is. So if you're not measuring these things, if you're not measuring how badly impaired the patient is, or you don't know your own complication rate, you can't adequately even make this decision. So I suggest we do this at the Beth Israel, where we measure Seattle angina scores for all of our patients undergoing CTI before the procedure and in follow-up. We quantify the risks. So you need to have a good understanding of these things before you can make informed decisions. So just for example, this patient with an unambiguous proximal cap, with good retrograde collaterals, for example, and a nice distal vessel, who's 57, who has a really impaired with angina, is just a different patient, than this patient on the right here. If it plays. If it played, you'd see that there was a very complex epicardial collateral that would be really a high-risk procedure in a patient who has much less angina frequency score of 80. Now I'm stuck. Well, I'll just go ahead and wrap up, and I'll say that so you have to weigh in about the risks and benefits and the individual characteristics of the patient, as well as knowing your own limitations. And the final thing I'll say is we don't have to make the decision sort of go or no go at the time that we decide on the procedure. At every point during our procedure, there's an opportunity to turn back, and we gain more information on this. So as you move forward in your procedure, you should be constantly weighing yourself, well, are the risks, I've learned something about the patient, are the risks different now than they were when I started this procedure? Are the benefits different now, and how do they compare to the possible benefits? I'd say that sometimes we can get locked into tunnel vision and go down this pathway where I think I have to succeed on a procedure without turning back, and that needs to be an ongoing assessment that we make. Thanks very much.